Hello, everyone. So good to see you here virtually. Please use the chat box to share your comments, your thoughts, your questions, your queries, anything that you want to share about, any topic you want me to organize a webinar on. We will be starting shortly in about 11 minutes as soon as Professor Adnan Siddiqui joins us. And it's a very important topic. Hope you will like the lecture today. Also, I will be sharing the link to the quiz. I hope that you know there will be a little quiz. It will be it will not be a graded quiz at all. It will be only for your own knowledge or self-assessment and practice. So I will share the link to the quiz during the session in this in the chat box, so you will be able to open it. It will be the form, it will be a Google form basically, so it's easy. And again, I'm telling you, it's only for your own practice and for your own knowledge, so you just have to go through those questions and try to solve them. The correct answer will be shown to you as soon as you submit the quiz. And also the link to download your attendance certificate will be shared during the session. So please keep an eye in the chat box. I will be sharing the link to download your certificate in the chat box. And again, so nice to see you all here. Please share which country you belong, which country you are in right now, from where you're watching the webinar. It will be so nice to know. It will be so nice to see you. And we will be starting the lecture shortly as soon as Professor Adnan Siddiqui joins us. Hello, everyone. So good to see you all here today. How are you feeling? From where are you attending this webinar? It will be so nice to hear from you and to see from where you belong, from where you are watching this webinar. Please use the chat box to share your questions, your queries, and if you have any suggestions or any comments, please use the chat box to share your thoughts, and also share from which country you are watching us from. And again, I want to tell you that there will be a quiz of after this webinar. This quiz will be non-graded, and it is purely intended for you to, it is purely intended to increase knowledge and for self-assessment as well as practice. So don't worry about it at all. It will be in the form of, a simple Google form, MCQ pattern. So it will be so easy for you to, you are quite, because everyone is quite, familiar with the Google form. So we have selected the same portal for this. And again, thank you very much. I will be sharing the link to download your own certificate of attendance during the webinar, during the session, by the end of the session, using the chat box. So again, thank you very, very much for joining. Welcome to the new attendees who have just joined. It's so good to see you here. Please share the country of your origin and from where you are watching us. It will be so nice to see you and meet you. We will be starting shortly in about 5 minutes as soon as Professor Adnan Siddiqui joins us. And as you know, he's a dual-trained neurosurgeon. Dual-trained neurosurgeon means he has both, the ability to, he's a neurosurgeon, but he's an additional training in international, in the neurointervention. Thank you very much, Dr. Paris. Where are you from? That's great. It's, it's obviously a very famous center. So good to see you. Thank you very, very much, Dr. Harshad Parikh, for joining today. So good to see you. You are a very regular attendee. So nice to have you here. Thank you, Dr. Paris. Obviously, so happy to meet friends from all over the world. It's so great. I think it is a privilege to have to know each other and to meet each other virtually on these platforms. Professor Siddiqui is here, I think. Hello, sir. Thank you very, very much for joining today. Thank you so much for joining us.
All right. Can you hear me?
Yes, sir. We can hear you. Thank you very much for joining us today, sir.
My absolute pleasure.
Thank you so much, sir. We were talking about you, and it's a privilege to have you here with us today. It's a matter of real honor, and I've had the honor of meeting you twice, once in Pakistan as well. So again, sir, thank you very, very much for accepting our invitation to deliver a very important lecture today.
Great. Well, I'm ready whenever you are.
Thank you so much, sir. I think we can start now because people have started to join the webinar. I know you have a very busy schedule ahead, so I think you can, sir, proceed. I just really want to give them a short introduction because I think everyone knows you so well. You don't need any introduction, but for the sake of formality, sir.
Go ahead, please.
Thank you so much, sir. Sir, I think your camera, sir, your camera is
It's turned off. Let me
yes.
give me 1
Thank
second.
you, sir. Thank you very, very much, sir. Yes, we can see you now. Thank you so much, sir.
Okay.
Sir, just for the formality. And sir, again, congratulations on your wonderful session that was going to be held during the CNS annual meeting in September on innovation. Sir, we are all looking forward to it. And I was actually planning to attend it in person. Hopefully, I may not be able to, but again, sir, it was a very important session and so intrigued to see all the innovations and everything being discussed by you. It's really so nice. So again, I really want to give just a few lines about your very kind introduction. Obviously, Professor Adnan Siddiqui does not need any introduction because all of us know him so well and we are all big fans of you, sir, indeed. And but for the sake of formality, he is professor and vice chairman in the Department of Neurosurgery at the State University of New York at Buffalo's Jacobs School of Medicine and Biomedical Sciences. He serves as the chief medical officer at the Jacobs Institute as well as chief executive. He leads the Cancer, Stroke, and Vascular Research Center at the University at Buffalo. He has special interest and expertise in the performance of complementary microsurgical, radiosurgical, and endovascular techniques for the comprehensive management of cerebrovascular conditions. Professor Siddiqui has spent over 450 peer-reviewed publications, more than 50 chapters, and about 70,000 citations with a very, very high H index. So it's a matter of real honor for us, sir, to have you here. So, sir, the podium is all yours, and thank you very, very much again for spending time from your very busy schedule.
Thank you, Noor-ul-Huda. I appreciate the invitation, and my goal here is to sort of primarily inspire those who want to proceed in this career, to show them all the interesting different kinds of things we can do to sort of move the field forward and take care of our patients who present with fairly complicated problems. So here are my disclosures, lots of disclosures of clinical trials, companies, and a variety of different opportunities to change the field in every opportunity, in every sort of forum that we can get. So starting off, we understand there are limitations to conventional microvascular neurosurgery. You know, you can only get the view that you get based on the access route you're taking, the approach you're taking. With aneurysms, despite clipping, 5% have some residual neck. So it's not as if clipping is absolutely perfect. Up to 10 to 16% may have residual AVM after microneurosurgery, so that's not perfect. And a lot of patients with cerebrovascular disease are critically ill, and trying to sort of address them under general anesthesia or transferring back and forth can be quite problematic. So there are issues. So let's just start by saying that's one fact. The second sort of fairly agreed upon fact, at least for now, is that digital subtraction angiography is the gold standard for assessing what you did. People have used indocyanine green, a variety of different other technologies, MRAs and CTAs, but none have the resolution and the 360 ability to visualize anatomy as well as digital subtraction angiography. So angiography is a key part of assessing the disease, but also assessing success of treatment. So the concept of a hybrid OR is put it all together in one place where you can do the microsurgical and you can do the endovascular You can do the monoplanar or biplanar, and you can do the anesthesia and neuromonitoring. So put it all in a room where anything you need to do can be done. So this is sort of our angio suite OR setup, which is the hybrid OR, which basically allows us to pin the head, do the craniotomy, and do the angioscopy. This is our actual room. So we use standard microneurosurgery, so you can see the patient's position. This is the radiolucent head clamp. This is the radiolucent navigation system. Here's our microscope, and here is an angio. And so microscope and angio coexisting. So there you can see I'm doing the operation while somebody else is getting access. And this allows, in the cerebrovascular era, really an ability to make sure that you get it right before you leave. So this idea that you can close the head and then bring the patient for an angio really means that in about 10 to 12% of cases, you got to go back to the OR and open the head. Why not put it all at the same time? And so I really feel that it's really useful for vascular procedures to really be done in a hybrid situation. And I understand many of you may come from geographies where it's kind of hard to imagine, but if you're going to construct a setup where you could do everything, this is the desired goal, that you confirm what you have done before you leave the operating room. So it really helps minimize transfer. So for example, you can imagine a scenario where you have to go to ICU, to OR, to ICU, to CT, to angio, to OR, to ICU. This, you just go one place and then to ICU for recovery. So, this really changes the ability to be efficient in terms of where we're trying to go. And this really allows now, with navigation becoming a very important part of neurosurgical procedures, the ability to integrate navigation with angiography. So not only can you confirm afterwards exactly where you need to go, but also that you got what you needed to do perfectly. And the same thing with AVMs and fistulae, et cetera. So it really helps a lot. And I'm going to now showcase just a whole bunch of little cases to demonstrate the point I'm trying to make. So here is a complex anterior communicating artery aneurysm in a 47-year-old, incidental, found because of headache. And so there you can sort of see standard AP and lateral. You see, well, there looks like there's something busyness going on in the ACOM region. Some tortuosity here in the vasculature. Everything else looks okay. Here's a 3D, and that shows there's the aneurysm. So it's kind of pointing ipsilateral to the left. And here we are going, and I'm going to sort of show you a surgical case. So this is a terional approach. So here you're opening the temporal lobe is right on this side. This is the frontal lobe, and we are opening the sylvian fissure. And they're very fairly straightforward, sharp dissection using micro scissors. Obviously, this is an accelerated video. We're now starting to see the optic nerve right here. This is the carotid artery. We're opening the optical carotid angle and just making sure that we can clearly continue to identify and separate all the key structures which are holding the brain tethered to the skull base. So that's the goal of surgery, is to get the brain to fall away and let gravity do its job. So that, look at how nicely the brain's just simply falling away by just cutting all of these little tethers. And there you can start seeing, that might be aneurysm. And so what we're doing here is doing a temporary clip spot, making sure that we have a nice place on the A1. So ICA is here, and there's the aneurysm. And you say, fairly straightforward. There's a little tether to the optic nerve here. I think we're exposing the neck. Should be fairly easy for us to do. And we think we can go ahead, and we're taking that little tether, final tether, to basically cut that, and so that we can really separate the aneurysm. And we think we got everything nicely exposed. And so once we have that exposed, we undo the other tether, and we feel, okay, we got 360 view of this aneurysm. Feel pretty good. Here comes the aneurysm neck, and we are going to put a clip across what we see is the aneurysm. Feel pretty good. Okay, take the temporary off. And we're going to take the temporary off. There it is. And then we're going to do indocyanine green and angio. And look at that. 1 second. Let me just stop there. This is our intraop angio. What do you see? We clip something. Of course, you all saw me clip something, but there's a whole lobe. So what happened was, because we have a limited exposure, what I thought was the contralateral A2 was actually more aneurysm. So what do? The head's still open, not a problem. Put a temporary back on. That other clip is still there. And now we can go after figuring out where the rest of the aneurysm, and see that. So this is the contralateral A2. This is aneurysm. So you now dissect this free. And once you have dissected this, you say, okay, here's ipsilateral A2. We might have to use a fenestrated clip to make sure we can get both. So now we're going on both sides, making sure everything is exposed. And now you can see I'm putting a fenestrated clip around the ipsilateral A2, adjusting and placing that to make sure that the aneurysm is clipped, but open it, pull it back. I want to make sure I pinch the neck here, change the angle. There it is. That looks much better. Okay, before we leave the OR, let's make sure we confirm that everything looks okay. Visual inspection is good. But more importantly, let's do that angiogram. There's the temporary coming off. And here comes the angiogram. Complete occlusion. All three branches of the ACA, 1, 2, and 3, are widely patent. That's the value of intraprocedural surgery. So let's do another case. Here's a 22-year-old female presented with an episode of seizures, no neurologic deficit, large AVM, a fairly diffuse nidus, dominant hemisphere, looks like it's a frontal lobe lesion. There you go. So large lesion, at least a grade 3/4. 5 staged embolizations, 5. And now looks like we really have the vast majority of this in check. This is all that's left. And after 5 stage embolizations, then now we go to the operating room. And this is a strip for brain monitoring. And here what you're seeing is, again, the subarachnoid planes, which are really critical. You can see the onyx. You can see, identify the margins in the cell size, so you know what you're going to leave behind and what you're going to take. And you continue to sort of dissect each branch by itself. And as these branches continue to become better identified, you continue to do this circumferentially. And so you've got this isolated. This is the draining vein. Obviously, that's the big vein that you want to make sure that we fully identify. And once all of that is there, then you start getting into the deeper part. So there you can see those vessels which are there. You can occlude and continue to dissect and find a plane and continue to dissect and find a plane and continue to dissect. And we continue to do this till we have the whole AVM identified circumferentially. And always you deal with the red devils at the very base, which are the tiny perforators. You got to make sure you get them all. And when it's fully surrounded, we say, okay, it's time for us to do the final resection. There is the draining vein being clipped. We are happy to take it off, occlude it. AVMs are still sometimes a little bit alive. Maybe a small straggler at the very base is still going. So this is the hard part of always trying to dissect the very root. And once that is done, then you basically pull this thing out, and this is what it sort of looks like. And you say, before I leave, it's gone. There's no residual AVM. And so that is the real key part of making sure that I didn't leave something small behind, because if we go back and we found the angiogram, we realize there's a small residual right here. All we do is take the Surgicel off and finish that before we close the head. So those are the kinds of things you can do, and the patient did extremely well. Here's another example. This is a patient who came in with the giant enlarging distal middle cerebral artery fusiform aneurysm. And so this was found for workup, was followed for years and years and kept getting bigger and bigger. And so she was referred to me because she had this ballooning distal M1 fusiform aneurysm. This is the vessel wall imaging that shows enhancement around the dome. This is what the aneurysm looked like. So it had both M2s coming out of it. And the diameter was such that which one do you sort of take down, because it's dominant hemisphere? You want her to move or to understand, risking one versus the other. So this is what we did. We actually did a radial artery to superior trunk bypass, and then clipped proximal and distal, and did a superior trunk to inferior trunk bypass. So it allowed for flow to go to both trunks. And again, patient did beautifully well, and we did the entire procedure in the hybrid suite. So we confirmed complete revascularization before we did anything. Now, there's another way of going about it. So what I showed you here was simple angiography, nothing fancier than that. Okay, so we did something complicated microsurgical and then confirmed its efficacy with angiography. There's another way of going about it, using the hybrid procedure to get access for endovascular therapy. So here's a 53-year-old, comes with a fistula, dural arteriovenous fistula, based on non-invasive imaging. So let's take a look. There it is. You can see there are lots of veins coming out, and there's a fairly straightforward path. So let me show you again. This is the middle meningeal artery, and this is the fistulous pouch. If we can get here, which we should be able to if we have a microcatheter that can get here, we'll be fine. But there is no microcatheter that can make all these turns. It doesn't exist. It's just too tortuous. So what do? Well, here's a fairly straight segment. Can we just directly get here for access, so we don't have to do anything else? So that's what we did. We didn't believe we could do that. And so we did a very simple, small, linear, using navigation, a little linear incision. And there is the middle meningeal artery from the outside. This is all bone. So we just drilled enough to expose the straight segment that was here, right here, a navigation. And there, I directly, using my hands, put a microcatheter into the middle meningeal. It bleeds a little, but usually not too bad. And there I am. That's exactly where I've gone in. And once I have that, I can now go exactly where I needed to go. And once I have that, I can cure this. And so that is the value of 6-month follow-up, no tinnitus, completely cured, where you use the OR, the microsurgery, neurosurgery, to do an endovascular procedure effectively. Another example is, carotid cavernous fistulae, particularly the indirect chronic types, which you can do going through the eyebrow. And so here's an example of a case where we did this. We had the eye surgeons expose the superior ophthalmic vein in the periorbital fat, and then we catheterized that, and there is a microcatheter going all the way into the cavernous sinus, and there's the onyx cast, and this is the cure. This is pre and this is post. more and more and more, we really don't need to open the eye. In the vast majority of cases now, we can just get endovascularly. This is a pretty cool one, was a real challenge. This is a 27-year-old presented with a temporal hemorrhage and seizures in 2006, underwent multi-stage embolization, 3 rounds of gamma knife in 2009, 11, and 13, still has residual AVM, presents with a reasonably well controlled seizure disorder. There it is. You can see it's a frontal opercular insular. This is what the AVM looked like. Truly not a surgical case. It's a ganglionic AVM in the dominant hemisphere with all these lenticular striates going to this. Post-embolization, 15 years ago, this is what was left. So this is early, this is latest, and 15 years later, this is what is still alive. It's still alive because look at the size of this vein of Lebet that's draining this thing. And so when you look at this and you say, this is being fed through no direct supply. So you have PL supply from the ACA and PL supply from the MCA collectively forming the supply to this residual nidus. So you've shut off any endovascular route to this AVM. We can't get to it. So I came up with an idea that I could go transvenous. There was this venous stenosis, which was a problem, but I thought I could sort of address that. So I thought I'll go transarterial and put a balloon in the ACA and MCA to stop those collaterals. That's step one. Then what I'm going to do is I'm going to take a microcatheter and I'm going to put a guide catheter into the vein, and then I'm going to put a microcatheter for onyx, and then another microcatheter for coils. I'm going to coil the vein shut, and then I'll inject the onyx to cure the AVM. And I'll do this all with venous pacing so that the blood's not coming to me while I'm doing it. So if I could do it, I think I could kill this thing pretty quick. So do systemic flow arrest, arterial control, and venous control all at the same time. Unfortunately, I could not do it because this venous stenosis prevented me from being able to access the draining vein. The flow was very high. I just could not get a wire to go in against the flow and fill it. So it's literally like a jet coming out, and it won't take anything going backwards. So what else can we do? We took her to the operating room. Same hybrid suite. There's the radiolucent head clamp. There's the X-ray system. Made a small linear incision. I was prepared for a full-on craniotomy in case I got into trouble, but I made just a small linear incision in front of the ear. And there is the setup. We have our venous access for pacing. We have arterial access for angiography. And there is, again, you can see how I'm holding the microcatheter just with my forceps because there's no other part. So this is the vein that allows, this is that big draining vein. So this is Lebet. And so once you have Lebet exposed, then what I did was I made sure I dissected the vein as well as possible. So we had circumferential access. And then the cool thing I did was actually look at the flow. There's the flow probe to see how much flow is going through the vein at any given time. And so there I am holding, again, the microcatheters. And so this is the cool thing. So this is the value of pacing. So pre-pacing blood flow is 119. Post-pacing is 37. And then when I inflate the balloon, it goes to 2 mils per minute. This is the value of pacing. It almost goes to nothing. Now, it's still anterior bulk flow, but it massively reduces the blood pressure. And so let's just show you how quickly this works. So this is to orient you. You have the draining vein. This is a hybrid suite, and I'm holding a microcatheter. Right there's the tip. I'm holding it with my forceps. It's leaking a little bit. So this is what the angiogram looks like. And I have a balloon in the ACA and I have a balloon in the MCA because the ACOM was good. So I wanted to make sure that we stopped flow. And there is the drainage into the AVM. And now you'll see the actual embolization. So there I have balloon up, clip on the vein, and look at how rapidly, this is live, we are curing the AVM. And this is, again, another view of the same. The AVM is filled with onyx within seconds. This is the final ECA angiogram. We went ahead and we finished off the external supply to the AVM, and this is the final angiogram, which shows absolute cure, and she did extremely, extremely well. So let's now go the other way around. So here you saw neurosurgery come in to help endovascular. Well, it can go the other way as well. Endovascular helping neurosurgery. So it's a 73-year-old coronary artery disease, neurologically intact, critical carotid stenosis, very heavy calcification. This is early on in my experience, where if I had to do this now, I would never do it. Severe hypoperfusion, because everything is kind of filling from posterior circulation, and comes in with NIH4 after an endarterectomy. And so when the patient comes in, we can see what are likely watershed infarcts. There you see between the ACA and MCA territory infarcts. So that means the patient's hypoperfused. Here's the perfusion study. There's increased volume, decreased flow, increased time. The classic definition of a brain really screaming for blood. Complete stump, completely occluded, post-endarterectomy. Most people say, oh, nothing to do, but that's not what we say when we have multiple options. So we go back to the OR, or maybe you could reconstruct this, because the problem is if you go to the OR, you can only see what you're opening, you can't really see above or below. So we used the Gore balloon system, where we put a balloon in the common and a balloon in the external. So all the blood would be coming back. So we had all the safety to be able to cross this recent endarterectomy, reverse the flow. So blood coming back is being reintroduced into the body through a femoral vein. So it can go back, so we don't have blood loss. There you can see the balloon in the external, balloon in the common. And then we use a wire, and there you can see the wire didn't want to go, so I used an MPA catheter, and here it is the wire which has gone across. And once I have direct access exposed, then I go ahead and place a stent to reopen the part that's closed. But then I realize there's still goobers sitting in here, but not a problem. We have balloons inflated. The goobers are not going to go anywhere. So we can now do intravascular ultrasound to see where they are, and then we just go ahead and stent them. And then we have a question about, okay, is this goober inside or outside? Well, it was outside the stent. Why? Because we did another IVUS to confirm no intraluminal thrombus. Once we are aware of that, we restore the flow, deflate the balloons. The patient did well, and again, recovered extremely well from the stroke that she was having from hypoperfusion. Here's a 32-year-old left hemispheric stroke, dense hemiparesis, smoked back a day, comes in, symptomatic 2 years later, again, recurrent right-sided weakness. And we look at the perfusion, and it looks like severe hypoperfusion of the left hemisphere with increased time. Looks like a moya-moya disease. And again, looks like the vessel is almost completely gone. We have a good STA there for possible bypass. So we go ahead and then do a bypass. And STMC bypass is done. There you can see the flow is going in. So we have a fairly good bypass done in the hybrid suite. And she comes back with recurrent symptoms and complete occlusion of the posterior branch, which was used for the bypass and development of collaterals. So what do? We take a radial artery, jump graft to the occipital artery branch, and there it is. We go ahead and do a radial artery bypass right there for anastomosis. However, she develops acute symptoms post-procedure, and we realize that when we do an angiogram, this artery, this is the bypass, you can see going up, is severely spastic. So this is my radial artery jump graft, severely, severely, severely spastic. Now what do we do? Well, we can go endovascularly and inject some verapamil. There you can see there's the angiogram, looks terrible. And this is good. That's the vessel that's feeding the brain. And we go ahead and do sequential angioplasty. Look at that. There's the balloon, 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 all the way down. And this is the flow. Remember the flow, how it looked when we started? Almost no flow in the brain. We got done with plasty, incredible flow into the brain. So that's the value of being able to do something both endo and open. Here's a pretty cool case as well. This is a patient who presented with a large recurrent PCOM aneurysm, had originally presented with the rupture 7 years ago, underwent craniotomy and evacuation, and then the aneurysm came back and then was coiled. However, the patient comes back in and there's big recurrence. So this is the original hemorrhage, which was treated. And now this is the that was the recurrence after clipping. So let me just stop there to orient you. Original CT, original clip, recurrence, and then coiling of this recurrence. So happy with that, but give it a little bit more time. And the patient comes back with this. So now we have a clip and coil and recurrence and a giant aneurysm. And by the way, this little thing you see here, this is the fetal PCOM. There is no P1 on the other side. So we got to preserve this fetal PCOM and treat this, and it's already been treated. So what do we do? Again, go endovascularly. This is the balloon guide. This is our aneurysm. And what I do here is, this is my fetal PCOM right there. And we access that. There you go. We're going with a little SIM2 technique. Push the wire, and there it is. I have access into the PCA. And once I have that access, then I'm able to drive my microcatheter across. There goes my microcatheter into the PCA. And once I am in the PCA, I confirm I'm in the PCA. There it is. And now what I do is I deploy a stent in the PCA all the way up till the PCOM. And there it is. That's the Elvis stent that's been deployed in the PCA all the way to the ICA to protect the fetal PCA. Then next thing I do is I deploy a flow diverter across the neck of the aneurysm. So there it is in the MCA. This is around the neck of the aneurysm. So we now have Elvis and a flow diverter going in. And once the flow diverter is in place, so flow diverter is from here to here, Elvis is from here to here. We left a microcatheter in the aneurysm. We already have massive stasis. And so now we can go ahead and coil till the cows come home. And there you can see at the end construct, you got a preserved flow diverter, preserved Elvis. And this is the final result at the end of the procedure. And again, 1 year follow-up showed complete obliteration of the aneurysm and did well. Continuing to show you in sort of interesting cases, here's a 54-year-old presents with altered mental status and GCS3 Huntes 5 subarachnoid, temporal lobe, big hematoma. So what do we do in a case like this? Well, we emergently go to the operating, this is a room, and do a hybrid angio to at least see what we are seeing. And it looks like a ruptured PCOM, right? There's a ruptured PCOM. So we go ahead and we try to go ahead and we go to the, I don't have the clipping, but we go ahead and we put a clip on it. And when we do the angiogram, the vessel is gone. We have an IC occlusion. There's something seems to be intraluminal. So we quickly catheterize the other side, and we realize the occlusion is limited. Luckily, the brain is still getting blood through the ACOM. Thank God for circular Willis. So what do? Do we go back to the OR? Do we open it back up? So we think maybe we'll just suck the clot out and see what we can see. So there's our guide, and here is a microcatheter, and we're trying to suck the clot out, and we just can't quite see very well. So I'm really nervous. And we take the aspiration catheter, and now we've got flow. There's a choroidal blush, there's a PCOM, no aneurysm. So what happened was when we put the clip on here, part of the thrombus that was sitting in the original right here got squeezed into the lumen. ICG did not show that. And if we had just left the patient to wait for a wake up, which grade 5 would be a problem, we'd have never seen. So, but we are not done. You can see there's a tail of thrombus still in there. So we went back in there and we try to go ahead and let's take another look. 2 minutes later, it's gone. And then what we do is second adapt pass. It still looks like there. You can see the clip, but there's still something there that's there. It's not working. So closes back again 5 minutes later. So we now bring the stent retriever, which I really didn't want to do in a fresh clipped aneurysm, but that's what we get after the stent retriever with aspiration. That's what was needed to completely recanalize, and that vessel now looks normal, no aneurysm, and the vessel's open. Again, amazingly young person, did very, very, very well. She had obviously grade 5, so she took a little while to get better. And this is CTA 4 months later, showing excellent reconstruction of the vessel. Just continuing in the same thing, sometimes it's not the endovascular, which is saving neurosurgery, microneurosurgery, it's microsurgery saving endovascular. And it kind of helps if I'm on both sides of the equation. I don't need to really sort of ask for any help. So this is another subarachnoid, large ACOM aneurysm, and we coil it and it comes back, and you coil it and it comes back. And this is then stent coil with an Elvis stent, and it still comes back. It keeps getting bigger. So what do we do now? So I tried to go from across the Elvis, which was ipsilateral A2, to make it into a Y stent and then coil it. I could not get access. So what do? We actually take her to the OR. This is interhemispheric fissure. So this is the Fox. This is the left side. This is the right side. The patient is in a lateral position. And this is the pericallosal. There's the corpus callosum. And we expose both pericallosals. There you can see the corpus callosum on both sides. And once we have that in place, then we are going to temporarily clip the two A2s. And there you can see they're being clipped on both sides. Then we are going to actually open the pericallosals on both sides, and we're going to do a side-to-side bypass. There we are marking the openings, and then we are actually doing the anastomosis and going through to make sure that we can see there we are doing the first stitch, and then we are doing a running, and it's an inside-out stitch that's needed in these cases to make sure that we can get them all done very well. There you can see, and what we do is we put them all in, and then we tighten, then we close one end, confirm everything looks good. They come back the other way, closing all the vessels. And once it's completely occluded, then we go ahead and say, okay, let's do a little angiography. And again, this is hard because it's deep. And there we're doing the final stitch. And once that is done, we then slowly start taking clips off. We put some Surgicel because we always want it to leak a little bit. It's a good thing when it leaks a little bit. And we now have flow, which is restored. And now what we'll show you is indocyanine green. Look at this. So this is contrast. It's clearly filling across the bypass. This clip is still on. Now I'm going to take that clip off, and you will see bypass fills, everything fills. So that confirms that this is a good bypass. It's working well. And this is immediate post result, where in the endovascular suite, we then coil the heck out of this aneurysm. and this is the bypass right here. And this is another view of the same. There's the bypass right there, and the aneurysm's completely cured. Another case here is a 60-year-old. Let's go back to the carotid. Presents with critical stenosis of the right side and occlusion of the left side. So this is the left side, this is the right side, very heavy calcium plaque. And we go ahead and we think, oh, she's got a coronary disease, maybe we'll put a stent in. So we go ahead and we put multiple plasties, we try to do the exact stent, and there is the stent, but it's so kinked, precise stent is so kinked inside that I can't get anything out, I can't get my filter back, and the patient is in trouble because they don't have good flow. Luckily, again, for the circular villus, they have some ACOM, but the patient is very labile, very pressure dependent, has these bilateral now watershed infarcts developing, and perfusion again shows a massive decline, especially already was bad in the left hemisphere, but now is bad on the right as well. And this is what the CTA shows, okay? And see how high this is. So this is C2, this is C1. The stent goes all the way to the base of C1, and there it is pinched by calcium. Well, what do we do now? It's high, but you can get there surgically. And so we went to the OR and we shunted. Above and below was really, really hard to do that. But that's what we needed to do to get the stent out. So, and then we pulled the stent out and the heavily concentric calcific plaque. And I learned my lesson. I've never forgotten that when you see thick concentric calcium in a carotid, don't stent, because you may have to go in and take it out. And so this is the post result with reconstitution of the carotid, and this is CTA, and the patient ended up reasonably well after a long hospital course. So, you know, I think that keep in mind that, you know, sometimes you make a wrong decision one way and you got to go to another strategy rather than keep digging yourself a deeper hole. So sometimes it's when one is difficult, the other may be easy. It's a cerebellar hemorrhage with subarachnoid from a dural AV fistula, Connier type 4. And look at this. This large vein with severe dolichoectasia and multiple venous aneurysms. Where is this vein? It's along the petrosal surface. So maybe, yeah, I could catheterize this and get into one of these transosseous occipital feeders. Yes, I sure could. But why not we go to the OR and find this vein. It should be the petrosal vein. So this is small temporal retrosig craniotomy. This is 7-8 complex. There is the vein right here. The first thing you see, even before you really get to the 7-8 complex. So once you have exposed this, and this is, you know, a sturdy vein because it's been arterialized for so long, there's no retractor. That's 5 farther down. We go ahead and just put a clip on this thing. That's it. Doesn't require complicated catheterization, transosseous, this and the other. Yes, it's invasive, but then we are not going to just coagulate, and then we cut the vein. No more fistula. Gone. So that's the value of being able to do these things endovascularly. And then the final category is true together, endovascular and microsurgery. 41-year-old who has a witness fall. 10 minutes later, she's extensor posturing, comes in with this large hematoma, likely from a possible middle cerebral artery hemorrhage. There it is. There we see it. We go to the OR in the hybrid suite. We take the skull off. We open the dura. So we have done the decompression from an ICP standpoint, so she's not herniating. Then we coil the aneurysm next. And third, there it is. That's the aneurysm in the hybrid suite. We coil it next. And then third, we go in and take the clot out through a small incision. And the patient did very, very well. Here's another example of retrograde and anterograde. So this is what is called transcarotid. So this is a person who comes in with right side stenosis, has critical stenosis with intraluminal thrombus at the origin of the left common carotid artery. And so what we do in this case, there is a pigtail. There you can see the proximal ICA. This is the SCM. We make a small incision above the clavicle and get access. There you can see we're getting access to the common carotid artery. And we're putting some Rommel tourniquets around the common carotid. And now we are going to catheterize. There you can see I'm putting a needle in and I'm catheterizing the carotid artery north. And once I have this in place, I'm going to go ahead and there is the critical stenosis of the carotid artery. And we are now going to place a stent after doing cerebral angiography. So we're doing cerebral angiography. There's our access. There's our IVUS. We are ready to do anything and everything that is needed. So this is baseline angiography. There you can see the critical stenosis of the carotid artery. And then we go ahead, easily cross this, plasty, stent. There comes the stent. And now this part is done. So and there we're doing an IVUS to make sure the IVUS looks good. That's where the stent is. So very happy with this. Okay, we're done with this. But remember that goober sitting down south. What do? We take this sheath and we swap its direction. So instead of going south to north, we are now going north to south. Exactly the opposite way. So there you can see again, this is where the lesion was. We have now Rommel tourniquet again, still there. So there's no anterograde flow. So we have flow arrest. And now we are crossing into the aorta. We have crossed. Now there comes a covered stent that we put right at the origin. We know exactly where it is because we have a pigtail. We can be very, very sure. There it is. You can see, I know exactly where this thing is. And I'm inflating the stent and trapping that goober behind the covered stent. And once you have done that, you now have restored flow and you can aspirate and there is perfect common carotid and we now, there you go. So we are really happy with that. We do our final runs, make sure everything looks good. There's an aortogram showing good symmetric flow and perfusion and the patient does very well. The problem with hybrid ORs remains, however, they're expensive. Vascular surgeons want them, cardiac surgeons, cardiologists, everybody wants them. So I think there are issues. Most importantly, they're expensive. But if all vascular disciplines were using them, I think you could get really high efficiency use. You'll need somebody to be the United Nations. But with that, I would maybe give some time for some questions before we wrap up. And I thank you very much for listening to me.
Thank you very, very much, sir, for the amazing and wonderful lecture. The cases were so amazing and everyone was in an awe. So thank you very much for your time and for all the wonderful cases. And I personally believe that it is so important to be a microsurgeon. That gives you the privilege of getting a better training in endovascular techniques, as well as selecting the proper patient, selecting the proper, making the proper strategy, as well as dealing with the complications. And in case you need to convert an endovascular procedure into a craniotomy, I guess it is basically more important to be a microsurgeon, a good microsurgeon first, than to have this additional hybrid training, which is the need of time. And I think it is very important for every surgeon, because basically I do have my own interest in endovascular, so all this neurointervention. So when I a few years ago I discovered that this is something that I need to be trained in. It is something that I need to practice, but obviously in Pakistan the facility is we don't have all those resources, but I believe that it is something very, very important. So again, thank you very much. There is, I think, one question that has just popped up. Dr. Nofal Bashir wants to know, is there any change in the dosage of heparin while you are doing simultaneous microsurgery and endovascular procedure?
Great question. So for what we do is we get access. We use the access for A-line, but we don't heparinize the patient. We just have this on an as an A-line flush, 30 cc's an hour or something like that. And then when we have completely exposed everything and we have good hemostasis, if we need to heparinize, we go ahead and heparinize. And then we do the endovascular part. And when the endovascular part is done, then we give protamine and reverse the heparin, and then we close the head. So these things can be done sort of, you can choreograph the right sort of way to do this, and it can be quite useful to sort of be able to know you need an ACT machine, you need to know go up, you need to go down. So yeah, there's some titration that's involved, but it's not as if you're trying to do a full-on craniotomy with heparin on board. Now, I do it with carotids on board. So carotid and TCAR, I have no problem, but usually it's not an issue in the vast majority of cranial cases.
Thank you very, very much, sir, for your very elaborate answer. There is another question, sir. By Dr. Harshad Parekh, do you always do decompression and coiling together or just microsurgery? What is your experience? I think this is a case to case. He wants to know your case selection. Do you always do decompression and coiling together or just microsurgery? What's your experience?
So yeah, this is my thought. I love aneurysm surgery. I showed you some examples of how nicely, subarachnoid dissection. It's enjoyable, it's pleasurable. I have some nice music playing and I enjoy them. That's not the case for a ruptured aneurysm. It's the proverbial, what we call the shit show. There's blood all over the place. The brain is swollen. It's herniating. And yes, you can clip it, but what clipping a ruptured aneurysm means is you have to be rough. You have to be aggressive. You have to suck whatever brain stands in your way to get to the aneurysm. You have to be ready for it to rupture in your face. You need to, take whatever veins that might be standing in your way, or veins that you take because you can't see because the sylvian fissure is filled with blood. You can't separate artery from vein. And so it's a much more dirtier operation when it's a ruptured aneurysm. And sometimes that's all you've got. But when a ruptured aneurysm comes in with a hematoma, the big problem is the mass effect. So if you go to the hybrid suite, you do a decompressive cranie, you take the skull off, you open the dura, now you have dealt with the acute ICP issue. Now, you haven't touched the brain, you go ahead and you coil the aneurysm, if it's coilable. If it's not, you can clip it. Once you have coiled the aneurysm, you are not any longer afraid of trying to get proximal control, distal control, split the fissure, this, that, or the other. Now you can just use an ultrasound to find out exactly what's the easiest, simplest, shortest route to the hematoma and just evacuate the hematoma. And so by breaking these things down into different parts, I believe we end up with a much better patient outcome than we just try to do everything traditionally through microsurgery. So that's what I do.
Great, sir. Thank you very much, sir. There are some message from AKU. Dr. Jalid Gilani is sending wishes from AKU, from the all the faculty of the AKU to you, and a big thanks for your wonderful lecture, sir. Sir, everyone is so much intrigued and so much impressed. Sir, again, thank you very, very, very much for sparing time from your very busy schedules today. It was so amazing to listen to your amazing talk and all cases. And since there will be a recording available on YouTube, I hope this will be so helpful for all of us to go through all your cases over and over again and to have a wonderful insight and more insight into all the cases. So again, so thank you very, very much for coming today.
My pleasure. I appreciate and I wish you all very successful careers and look forward to running into many of you across the globe. Have a good day. Thank you very much.
Thank you so much, sir. Thank you so much, sir. So nice of you. Again, thank you very, very much, everyone, for coming today and for joining us today. Please use the link I have shared with you to download your certificate, and also the link to the quiz. Hey, I'm sharing you this link to download your attendance certificate now. You just have to click on it and send me an access request. I will give you the access to download the link. Thank you very much, Rosanna. It was my own pleasure. You know, I've been through all this myself. Use this link, the shorter one. This is the direct quiz link. The other one might be a little cumbersome. And this is the link to join our WhatsApp group, so you can stay connected with us. And here is the link to download your certificates. So it was so good to have you all here, and the recording will be available on my YouTube channel. I hope you have subscribed to it as well. I'm sharing you the YouTube link as well. This is the link to download the certificate. This is the link to the WhatsApp group. And this is the link to the quiz. And the link to my WhatsApp group, and I'm sharing now the link to my YouTube channel. Please subscribe to the channel and also visit the Neuro website, because I have got so many free projects for you, including a free journal that you might find helpful. And there are some free courses that I'm running. So again, thank you very, very much for joining today. Please let me know that you have got all these links. So, and if you have any comments and suggestions or any topic that you wish me to organize a webinar on, please share it in the chat box, and I will be so happy to organize a webinar on that particular topic. I think it is amazing to learn together and to introduce ourselves to new concepts and new things. So I'm a young neurosurgeon myself. I believe that it is a huge privilege to have a chance to learn from the biggest neurosurgeons. Access code, no, it's not a code. You just have to send me a request and I will send you an access after the webinar ends. I will be sharing, I will be giving you all access one by one in an hour or so. So thank you again, everyone, for joining today. It was amazing to meet you virtually, but obviously it's so good. Please do subscribe to my YouTube channel, as well as the WhatsApp group and also the website, because I keep on updating and adding more things, you know, more frequently, and there are also more webinars that you might like. And if you wish me to you know, organize something that you wish to know, to learn more about, then you can email me. Okay, I'm showing you my email address now. You can email me and I will be so happy to organize a webinar on the topic you wish to learn more about. So again, thank you very much. Thank you, Yuza, Laurenelis, Salazar, Layato. Thank you very, very much. So good to have you. Thank you so much. It's amazing to receive your wonderful, wonderful data, your wonderful feedback. Sorry. Thank you so much, Rosanna. Thank you so much. So I'm just